Hey guys, I just wanted to make a quick video about arterial pressure reading and just kind of like how it's calculated and the kind of like the engineering and physiology behind it. ICU patients are pretty sick and they require continuous blood pressure monitoring, and that's achieved by placing arterial catheters. They're either placed in the radial artery, the femoral artery, sometimes even the axillary. What you get is this cool looking picture over here towards the right, basically a graphical representation of the systolic blood pressure and the diastolic blood pressure. And once you subtract those two, you get a pulse pressure. The two things that the pulse pressure is dependent on is the stroke volume, the amount of blood that is pushed out of the heart with one contraction, as well as the compliance, inversely proportional to the compliance of the vasculature or the arterial vasculature. If you follow the graph, the first part is the upstroke that's circled right over there, and that leads to the rise to the peak. That top point is the systolic blood pressure, and then you have like a little divot that's called the dicrotic notch, which indicates the closure of the aortic valve, and then you have a slow diastolic relaxation, and the end point, the lowest point there, is the diastolic blood pressure. So as I mentioned, the two determinants of the pulse pressure are the stroke volume and the arterial compliance. So if your heart is pumping out blood, like with aortic regurgitation, you're going to have an elevated tracing. The rise is going to be elevated. It's going to give you a high SBP. And similarly, if you have like really poor compliance, like with atherosclerosis, you would also have an elevated tracing. Dope. We're able to get the systolic blood pressure and diastolic blood pressure. Like, why is that important, right? The area under the curve represents the mean arterial pressure in the major arteries. That's the principal driving force for blood flow for the entire system. And as I said, it's measured electronically under the area under the curve. There's a formula that we learned in med school, which is 1/3 systolic blood pressure plus 2/3 diastolic blood pressure, that you can use to calculate the mean arterial pressure. But for patients in the ICU, we generally don't like to do that because that formula assumes the heart rate is 60. That's why this arterial tracing is so important. Before I keep going on, I just want to touch a little bit on kind of the physics and engineering about how this is all done. So in the ICU, when you're putting in a art line, basically you're putting a little catheter in whichever artery, and that's connected to a long tubing that is connected to a transducer, which is connected to a computer, which is connected to the screen, and you get this cool looking drawing. So these systems are basically, they're resonant systems, and the resonant systems are dependent on two things, resonant frequency and the dampening factor. So you got your blood pumping, assuming the patient is alive, and that blood is going to be moving up and down in a column in the tubing, right? So that frequency of it going up and down, that's your resonant frequency. If one waveform is met with another waveform before the cardiac cycle is complete, you get an amplification of the whole waveform. And these systems are called underdamped systems. This is a problem because it's going to overestimate the blood pressure. And then you have overdamped systems. Basically, that extra wave that's coming in, the computer dampens it by a factor. This concept of dampening is actually incorporated in the body by itself as you move from the different parts of the circulatory system. As you go from the proximal aorta, the femoral artery, the radial artery, the arterial capillary, it depends on the resistance of blood flow and the compliance, which is delta V over delta P, or in other words, how much volume vasculature can hold per given pressure. So the two different spectrums in this diagram, all the way on the top you have the proximal aorta, and then all the way on the bottom you have capillaries. So you know that the capillaries are super compliant, therefore they can hold a lot of volume for a given pressure, as opposed to the proximal part of the aorta, which is less distensible, less compliant. So the more compliance you have, you're going to have like a less sharp waveform, because that vasculature is going to be able to hold more volume without really pushing on the walls really hard. Resistance will also dampen the pulsations because blood has to move forward. As the blood moves, the pulse wave from the front tends to distend the part of the blood vessel that's coming up. So the greater the resistance, the harder it is to move blood forward. I've bored you guys with all the physiology and a little bit of engineering about how all this happens. Let's talk about the money. Why is this clinically relevant? So I was telling you the map is the area under the curve that we just described, and it's the area under the curve per given cardiac cycle. And we talked about how you calculate it mathematically, but we don't like to do that in the ICU because that assumes a cardiac cycle is like 1 minute, and that's really not often the case in the ICU. And the map is basically, we can use the map as a measurement if tissues are getting perfused adequately, and the cutoff for that is 65, generally speaking. So going back to a little bit of physics, the flow of a stream of blood or anything is equal to the pressure that's coming in, the pressure that it leaves, divided by the resistance. If we exchange these variables for cardiovascular variables, we're going to get cardiac output, which is synonymous to the flow, is equal to the mean arterial pressure, the pressure coming in to the circulatory system, minus the right atrial pressure, the pressure leaving the circulatory system, divided by the SVR, the resistance. And if you rearrange that formula, you can get the map. Map is basically the cardiac output times the SVR plus the right atrial pressure. Now, the right atrial pressure is generally negligible unless there is right-sided heart failure. You can usually say it's like 0. And these values really become important when you're evaluating shock. And just touching on the 3 basic shocks types, there's hypovolemic shock, where you have a decrease in volume, and that will be represented by a decrease in right atrial pressure. If you have cardiogenic shock, your cardiac output will be low, and if you have vasogenic or septic shock, you're going to have decreased vascular resistance. So that's really all I got. That's basically how you interpret in arterial tracing, kind of figure out where in the body you are, and why it's important, how it incorporates into getting the mean arterial pressure, and how you can use the arterial tracing as well as the map to help you determine what kind of shock there is. If you guys thought this video was helpful, please let me know. If it was absolute trash and I wasted a couple minutes of your time that you're never going to get back, please let me know.